I'm Arvin Narula. I'm an interventional cardiologist in San Diego. And today I'm going to talk about how not all calcium is created equal. So, obviously we deal with calcium on a daily basis. We've seen this in all of our cases where basically our stent is sometimes not expanded, especially in a circular fashion. And that's because there's usually this huge nodule that's preventing our stent from fully expanding. So again, there's different types of calcium. There's the concentric calcium type, the eccentric calcium type, and the nodular type. So today I'm going to focus a little bit on the nodular type of calcium. So calcified nodules, why do they happen? The theory is it happens at increased sites of increased torsion, particularly in the right coronary artery. About 50% of these are in the right coronary artery. So basically, what are they consistent of? Higher prevalence of necrotic core, especially compared to the adjacent regions. And then there's this hard collagen-rich calcium kind of around that, and it looks like a little boulder or mountain that's kind of protruding into the artery. And this is something that kind of I was learning about too, because again, you do a lot of imaging, then you read more OCT stuff and IVUS stuff, and you realize that there's actually histologically two types of calcium nodules. There's the eruptive type and the smooth nodular type. So the eruptive type actually has these small dense fragments, and it looks like there's a fibrous cap basically with disruption and some thrombus on it. So if you look on OCT and even on IVUS, I kind of look for what looks like the Rolex crown logo, and that kind of helps me differentiate if this is the eruptive nodular type or the smooth nodular type. The smooth cap nodular type is kind of looks almost like an eclipse or like a bowling ball type thing. That the theory is that this is kind of like a healed eruptive nodule. And again, when we're dealing with calcium, from our standpoint, we have atherectomy devices and things like that. And we've occasionally had these no reflows. It just makes you wonder if we're doing atherectomy on eruptive nodules, is that what's causing our no reflow, or is it just all this debris going downstream from the calcium itself? So it's all kind of theories. The more we image, the more we learn, I think, and the more we're going to continue to learn, especially in this space. So again, intravascular lithotripsy, modifying this eruptive calcium nodule. Here's a nice example of this. Again, this eruptive calcium nodule, here's I call it the Rolex crown, right? It's kind of protruding into the vessel, and you kind of see that. But after IVL, it looks like it's actually kind of crushed, pushed back, and deformed. And then this actually shows some nice concentric circular expansion of a stent after IVL therapy. So again, there's always limitations to the current tools that we have. Standard balloons, especially even non-compliant balloons. Where does the stress occur? The stress occurs at kind of this junction between the calcium and the healthy tissue, and it doesn't do much to here, because what ends up happening is, you just end up dissecting or sometimes even perforating the junction between the calcium and the healthy tissue. So that's why IVL was created to kind of make this portion of the vessel way more compliant and kind of fracture those calcium plates, especially in the deep vessel. So again, histologically, this kind of shows IVL being able to not only help with the nodules, but also fractures the deep plates within the vessel itself. So again, historically, nodules have been even treated with rotational atherectomy, they just have worse outcomes. So here's some curves showing calcified nodule versus non-calcified nodule, pretty much every category. I mean, it's been a challenge for us, and this has been an issue for us for quite some time now. But hopefully, with evolving technologies, evolving techniques, and more research that comes out, we can kind of conquer this space as well. Again, I think where IVL potentially offers a lot of benefits is it doesn't really depend on pressure of the balloon or anything like that. It actually targets calcium versus soft tissue. It's actually able to modify deep calcium. And some of these vessels are tortuous, and you can sometimes have wire bias with the rotational atherectomy, and you may not be able to ablate the areas where you want. And again, there's a lot of different sizes where again, this is pretty much independent of luminal size. You can find an IVL balloon that will fit this vessel and treat. So again, if you look at this, intravascular lithotripsy shows a lot of consistency with within calcified nodules. This light blue slide kind of shows that MLAs and MSAs are actually on par with non-calcified nodules. So again, the data on this is starting to come out, especially from this Disrupt for CAD trial. This was a sub-study, OCT sub-study, looking at MSAs and MLAs post IVL, despite the presence of nodular calcium. So again, looking at this, patterns of stent expansion in nodular calcium, almost over 3/4 of this of these cases were actually shown to have concentric expansion. So it's actually, again, pretty impressive, and I think it's definitely part of this armamentarium that we should keep in our back pocket, especially in again, this nodular calcium. So again, I think data is coming out on this now. This was presented at EuroPCR, but basically what you're seeing is pretty consistent outcomes in patients with or without nodules. And this is at 1 year, but again, I'm sure we're going to start collecting more and more data on this long term. So again, the real world nodular calcium algorithm, it kind of goes like this. Okay, well, I see some calcium there. Let me see if I can advance an imaging catheter. And again, I kind of have this eagle eye IVUS, the big chunky one. Half the time it doesn't deliver. And my algorithm is, if it doesn't deliver, I may need something to modify this plaque. So, what my question for the folks watching is, what's kind of your algorithm? Do you just go up with a compliant balloon to a non-compliant balloon, and it's a non-compliant balloon expands? Are you putting stents in? Are you more likely to use lithotripsy balloon, or do you kind of use this cutting and scoring balloon, or do you just go with atherectomy, particularly in the cases where you can't really deliver anything? So this is a nice little thing Dr. Robert Riley kind of shared with me. I think this is a really nice algorithm. Basically, it starts with imaging, and you use your IVUS and OCT assessment. You look at calcium arc, calcium length, and thickness. So if you have your 5 points, you're more than likely going to benefit if you use some kind of calcium modification technique. So again, kind of looking at this, if your imaging catheter is not able to cross, or the DOINC algorithm, you kind of look at and use whatever strategies you use for your wire is across but balloon, wire is across and equipment won't deliver. You start going to that algorithm, and then eventually, once you're able to break through that, you reassess, reevaluate. Is there still residual calcium, or do you use an NC balloon and kind of work and get that and look for 1-to-1 sizing? So some of these cases, imaging criteria is not available. So sometimes an NC balloon, if an NC balloon is able to kind of expand in a 1-to-1 fashion, especially at nominal pressure, then okay, go ahead, proceed with PCI. But if not, if your NC balloon kind of has that dog boning appearance, that's where again, you're likely going to be able to deliver a shockwave balloon. So you perform your lithotripsy and then proceed with PCI. So I think this is a nice little algorithm for most folks. It's easy enough, easy to remember, and I think this is one thing that we'll continue to keep learning on and going forward. I mean, what's the role of atherectomy plus IVL versus IVL alone versus just using our standard traditional therapies? It's a space where it's been a challenge for us all the time. I think hopefully IVL will help us improve our outcomes in this space in conjunction with other devices or standalone therapy. I think those answers are going to be coming in the future.